and I hear from a lot of colleagues that there is not enough level of professionalism in your class.
What?
The reason is that, yes, you're very young in age, okay? We've all been through your shoes. We're not judging you. We're expecting a lot from you. But what is the most frustrating aspect is the manners that you exhibit. I've heard also from the girls, from some girls, and especially you boys, which you should be the gentlemen, that you're not being respectful. Now, we're not here to penalize anyone. We don't really want to be dealing with attendance. Whoever wants to attend, they can attend. We're just here for you to be able to understand. If you do not understand something, it means that we're not doing our job properly. Okay? So this is what you should demand. Late? Why are you late? Why? First of all, why are all of you late? Give me a good excuse.
I went to get my iPad, but I remembered it's here.
Okay, I will excuse you for now, but please, we won't have any classes together, but not for any other colleague, okay? All right, take your seat.
Thank you, sir.
Very well. All right, so I expect that you're all gonna be much more professional because there is a level of frustration going on around. In any case, do you agree with me or not?
Yes, sir.
Okay. So today we will be talking about the autonomic nervous system again, and our lecture today is going to be about the adrenal medulla. Now, as we said in our initial lecture, the adrenal medulla is one of the organs of the sympathetic nervous system that has direct inputs from the spinal cord all the way to the effector organ. And this is being done by spinal nerves extending freely all the way from the spinal cord without synapsing before with any ganglia of the sympathetic chain. Excuse me, why are you late?
We didn't know you came in.
Okay, go back out of the class.
Okay.
Thank you.
So, these free nerve endings, which they release what type of neurotransmitter? Acetylcholine, and they activate nicotinic receptors at the visceral organs. Now, today we'll be talking about the differences between the action of epinephrine and norepinephrine that is being secreted by the adrenal medulla, the denervation hypersensitivity, and how these nerves adapt after a nerve is being severed. And we'll be talking about the centers of the brain that are responsible for regulation of heart rate and respiration. Now, release of norepinephrine in the bloodstream usually takes 5 to 10 times longer duration than direct sympathetic stimulation. In order for adrenaline or norepinephrine to be relieved from the bloodstream after it's being released, it usually takes 2 to 4 minutes compared to direct sympathetic stimulations that takes much less time, approximately 10 to 30 seconds. Epinephrine, it's a much more potent excitator when it comes to the heart and the bloodstream. So as soon as epinephrine is being released, and this is usually being done during the fight or flight response, during mass sympathetic discharge, we have a much stronger mobilization of also the musculature. This is being done through the adrenal medulla, which secretes approximately 80% epinephrine and 20% norepinephrine. In the occasion that I have what we call a pheochromocytoma, which is not necessarily a type of tumor, but rather of an abnormality of tissue development in the adrenal glands, then I have an excessive production of norepinephrine, which is going to lead to a greater peripheral vascular constriction and an elevation in blood pressure, and to a lesser extent, the release of epinephrine. Now, in order to inhibit the effect of the pheochromocytoma, then we need to apply either adrenergic antagonist, alpha, necessarily, for the dilation of the blood vessels, and at a later stage, beta antagonists. So, in the occasion that we do have a pheochromocytoma, these are more or less the symptoms that the patient is going to be facing. Along with this, we're going to have a cold sensation throughout the body. So not only the individual is going to be appearing with cold, clammy hands, cold and sweaty hands, but also in general, the temperature that is being produced by the body is going to be much more reduced. So along with this, we're going to have high blood pressure because of an increased peripheral vascular constriction. We're going to have heavy sweating because of the stimulation of the sweat glands, headaches, which are a byproduct of increased blood pressure, rapid heartbeat because of excessive activation of beta receptors, tremors, which is also part of the metabolic output that the Pheochromocytoma exerts at the visceral organs, and paleness in the face and shortness of breathing. Now, epinephrine, as we said, it has a greater effect on the cardiac output. So, as soon as epinephrine is being released in the bloodstream, I have an increase in cardiac output and contractility. Now, norepinephrine comes and tops up this effect, and because it causes an increase in peripheral vascular resistance because of the constriction of the blood vessels, then I have a further increase in blood pressure. Now, in addition to this, epinephrine exerts another metabolic effect, and this is the glycogenolysis and calorinogenesis in the liver. This is being done because upon stimulation of the adrenal medulla, which happens usually in excessive cases of stress, such as in the occasion of a predator. Also nowadays, if, for example, you're having a stressful exam or you are under a stressful social situation, then we would also need a greater metabolic output and a greater caloric response so that more energy is being supplied by the mitochondria for muscle mobilization. So the pheochromocytoma will need to be removed from the body in order for the normal functioning of the visceral organs again to take place. Now, in the occasion that the adrenal medulla is being removed, this is not the end of the world when it comes to the internal organs, for the reason being that I still have postganglionic sympathetic fibers that are innervating the smooth muscle of the visceral organs that are gonna have an effect in elevating either heart rate or leading to several other effects. Now, in the occasion, however, that I have a removal of certain of these postganglionic sympathetic nerves that would release norepinephrine, then I have an adaptation at the receptor. And you might be wondering, what is this adaptation that is taking place? So, despite the nerve might be completely removed, there is still some other sympathetic innervations that are reaching the organ. And a very small impulse needs to be given to the organ every few seconds in order for the organ to be activated and make the appropriate physiological responses for homeostasis. Now, after the nerve is being severed, it usually takes minutes, days, or even weeks for the receptor to adapt again to the loss of this sympathetic innervation. And this is what we call, this chemical adaptation is what we call denervation, supersensitivity, or hypersensitivity. And how does this look like in physiological terms? As you can see from the graph over here, we have plotted a nerve being severed in one of the peripheral vessels of the arm. Now, peripheral vessels of the arm, they definitely supply blood, right? As norepinephrine is being applied at the first curve that you see a small dip. Here you have the X and Y axis. So the vertical axis represents the blood flow to the arm, whereas the diagonal, it represents time. Now the vertical axis, you see that as soon as we apply, let's say 1 milliliter of norepinephrine, this blood vessel starts constricting. And by constricting, it also restricts the blood flow to the arm. Now, as we sever this nerve, we see that there is no more sympathetic input to the blood. So there is more blood flow, correct? As you see, the curve further up, after stellate ganglionectomy, you see that the blood flow is much more because there is no more any sympathetic innervation to the blood vessel. Now, after a period of 4 weeks, since the receptor has now adapted to this removal of the nerve, we see that by applying the same amount of norepinephrine of 1 milliliter, we see a much bigger response at the blood vessel. So blood flow is restricted even more. So by applying 1 milliliter after 1 week, the receptor is much more potent in responding to this small amount of norepinephrine. The reason is because the receptor now has become even more responsive to the free circulation of norepinephrine being circulated in the synaptic cleft. And this is what we call denervation supersensitivity. There is a question, yes?
What is the reason for the increase after the second week?
You mean that the increase in the drop, the blood flow decrease or blood flow increase?
Blood flow increase.
Okay. The reason because of the blood flow increase is because the receptor is not receiving enough norepinephrine to modulate an equal blood flow. So as soon as the receptor is being removed, the norepinephrine now that is being released is not enough for the homeostatic balance of blood flow. So blood flow to the arm is even much more because there is not enough norepinephrine being released. So the nerve is removed, or part of the nerve is removed. So the norepinephrine that is being provided to the organ is much less. And since norepinephrine is much less and the receptor has not yet adapted, then blood flow is going to be even more. Makes sense now?
Yes.
Wait, what's stellate ganglionectomy? What does it remove?
Why is it removed, you said?
What does it remove?
Okay, and what does it remove? So in the occasion of ganglionectomy, so you need to remove, let's say, a specific organ. You need to remove, you need to dissect, or you need to cut, the surgeon needs to cut from a place in the abdomen to innervate a specific organ. It could be the kidney, it could be anything. Now, during this process, certain nerves are gonna be severed, and these nerves would supply norepinephrine to either the blood vessels or certain internal organs. Now, the organ, the receptors of the organ, despite the fact that the nerve has been removed, they're gonna adapt. They're gonna adapt either by responding to the free circulation of steroid hormones in the bloodstream through the adrenal medulla, or they're gonna adapt so that even if one of these nerves that is being severed is still attached to the smooth muscle of the organ, it's gonna be much more responsive this time. Okay, can someone name two differences between norepinephrine and epinephrine? Yes?
Epinephrine increase the blood pressure.
Yes?
Norepinephrine decrease the blood pressure.
Okay.
Epinephrine make the cardiac pump faster, and norepinephrine decrease the blood, the cardiac pump.
Okay.
Almost there, almost there. Let's hear some other opinions, yes?
And the epinephrine in the small intestines, it slows down the muscle contraction of the muscles in the small intestines, but norepinephrine speeds up the contraction, stimulates the muscles.
Okay, and?
Epinephrine causes more of glycogen metabolism than norepinephrine.
Yes, that's correct. Okay, so again, I'm glad that you participated, and thank you very much for being courageous to give your answers. Now, epinephrine has a much greater effect when it comes to heart output, so it increases contractility of the heart, okay, and blood flow. However, blood pressure is not gonna go up unless norepinephrine constricts the blood vessels of the periphery. So norepinephrine has a greater effect on blood vessels because it leads them to constrict, whereas epinephrine is going to have a greater effect on cardiac output. In addition to this, epinephrine also has a greater effect when it comes to glycogenolysis and calorinogenesis. Loss of sympathetic or parasympathetic nerve causes adaptation at the receptor level. What is the name that we give to this adaptation?
Chemical adaptation.
Chemical adaptation, denervation supersensitivity. Yes. Now, yesterday or 2 days ago, we talked about certain reflexes. One of these reflexes that we talked about is the baroreceptor reflex, right? When we went from supine to standing position. And this, which they're specialized baroreceptors, they modulate heart rate. So as soon as someone stands up and blood flows to the extremities, then it's gonna down-regulate parasympathetic activity, which deals with the relaxation of the cardiac muscle, whereas sympathetic outflow is gonna be increased for more pumping of blood. Now, this is one of the reflexes that we talked about. Another reflex, which is under the influence of certain psychological stimuli, is the gastrointestinal reflex. And the gastrointestinal reflex, it doesn't only involve the secretion of digestive juices by the stomach, it also involves salivation. So if you're hungry and you see a very tasty burger or a very tasty food that your mom cooked or you smell it, then all these gustatory reflexes are gonna start taking place. Other reflexes of the autonomic nervous system include the bladder that we talked about, as well as the large intestine, which more or less works in the same manner as the bladder. Now, in occasions of excessive stress, we're talking about a reflex that is called the mass sympathetic discharge. So under this reflex, let's imagine that you're falling off an airplane with a parachute. Then you will have the sympathetic nervous system taking over all over your senses. It will dilate your pupils, it will lead for your muscles to contract, it will lead to an acceleration of heart rate, and this is what we call a mass sympathetic discharge. Now, this type of mass sympathetic discharge has been developed throughout the centuries because in the occasion that you're being cut by an external stimuli, such as, let's say, during war, then you would not die from excessive bleeding because vascular constriction is going to take place so that you won't die from a simple cut. So this is what the mass sympathetic discharge does for you and the sustenance of your life. Now, the last part of our today's lecture, those of you that are trying to sleep right now, please try and take a little bit more comfortable position, or if you want, you can also stand up and sit down again. I understand that again after food, you're also digesting your food and you may feel tired, okay? Please try and pay attention for another 5 minutes, we're almost done. So over here we have a diagram of the cortex. So you see the neocortex, which is basically the frontal cortices all the way down to the cerebellum. Now, in the middle, you have the limbic system, and further down, you have the brain stem. It says here midbrain, pons, and medulla. This is the part that I want you to focus on. Now, in neuroscience, how we got to know that different parts of the brain control different aspects of the autonomic nervous system or certain behaviors, we followed a method of deletion or a method of stimulation. Or we recorded activity from certain neurons. Now, in the occasion now of the autonomic nervous system, we got to know that the brainstem is responsible for heart rate by severing the nerves that pass from the neocortex to the brainstem. So we transected the brain from the midbrain up. And what we've seen that the neocortex has no effect when it comes to cardiac acceleration or deceleration. Heart rate kept continuing normally. However, when we severed the brain from the medulla and down, basically we stopped the communication of the brain stem with the spinal cord and eventually the sympathetic chain. And what we've observed is that by severing the brain from the medulla down, that heart rate started decelerating. And this is how we got to know that the brainstem, and particularly the medulla and the pons, the pontine and the medullary structures of the brain stem, they control heart rate and pulmonary action. Can someone name two autonomic reflexes for me? Yes?
Fight or flight.
Yes, this is also a reflex. Yes? Yes, that's a reflex, yes. In general terms though,
Cardiovascular baroreceptor.
yes, this is an autonomic reflex. The blood pressure reflex by baroreceptors, yes?
When you see food,
Appetizing food, yes.
so just your ERT starts to prepare for.
Yes. Okay, very good. By which parts of the brain is respiration and heart rate modulated by? Medulla, yes, and pons and medulla. Okay, very good. In the view of a predator or a challenging situation, what is this that we call mass sympathetic discharge? Now, this brings us to the end of our today's lecture. In our previous lecture, we talked about muscarinic antagonists, agonists, and so on. Now, all these drugs, the sympathomimetic drugs or the parasympathomimetic drugs, they act at the different levels of the receptor or the neurotransmitter level. They could either lead to the mobilization of certain amino acids to produce more of these steroid hormones. They could either block the essential enzymes for the production of norepinephrine or acetylcholine. They could block receptor intake by the receptor level, or they could even block the receptors so that there is more circulated acetylcholine or norepinephrine being circulated in the synaptic cleft, constantly reactivating the visceral organ. Now, all these, they're not required, I don't want to require you to know about this, but it's a good introduction for you to know later that you're going to take pharmacology on how these type of things, they will come into play. Do you have any questions regarding your previous lecture? You all understood quite well preganglionic and postganglionic.
Doctor, in the last lecture you said sometimes we have preganglionic but not postganglionic. I didn't get this in this point. Can you repeat it?
Okay. So one question was, in some occasions we have preganglionic, but we do not have postganglionic nerves. In the occasion that we do have occasions as such, one of these occasions is the occasion that we've seen today, the adrenal medulla, which we just have free nerve endings extending all the way from the spinal cord to the effector organ. And we also have the cases which is not really free nerve endings, such as in the occasion of pilorectal muscles, blood vessels of the skin, and also sweat glands. Now, these sweat glands is not necessarily the fact that they do synapse with ganglions on the sympathetic chain. However, they pass back from the sympathetic chain to the spinal nerves. And this type of nerves is again an anomaly like the adrenal medulla. However, they do synapse with ganglia. The anomaly lies on the fact that they're being stimulated by acetylcholine and they activate nicotinic receptors. Okay? This is basically the difference. The only organ that receives free nerve endings all the way from the spinal cord to the organ that it affects is the adrenal medulla. No other organ. Yes?
I have a question. If in the last lecture, the post or preganglionic neurons are what are releasing epinephrine, then what does the medulla do?
So if the postganglionic neurons release norepinephrine, what is the role of the medulla?
Yeah.
Okay, the role of the medulla is that when it gets activated, and because you have the release of epinephrine in the bloodstream, or norepinephrine, is the fact that the medulla, the way that it activates the organs, it takes much longer. It's a much more efficient way to activate all the organs because it takes 2 to 4 minutes to be removed from the bloodstream through the liver and through the tissue of the organs. So why constantly stimulate this type of postganglionic nerves that are going to release their synaptic transmitters, and after a while they're going to get catalyzed from 10 to 30 seconds. Whereas this gland is much bigger, it has a much longer lifespan and much more effect. And usually a stressor lasts some minutes or some hours. Unless we're talking about mental illness, where we have the excessive release of catecholamines by the bloodstream, which will eventually gonna deplete the glucose levels that are present in the soft tissue.
So,
What happens if you denervate the adrenal medulla?
If you denervate the adrenal medulla so that it doesn't receive the inputs, well, by denervating the adrenal medulla, eventually you're just giving space for direct postganglionic sympathetic nerves to stimulate the vessels.
I mean about the release of the adrenal medulla itself. If you denervate it, does it have a tonic release level, or is it completely wrong?
By denervating, if it doesn't receive inputs, then no, it's like removing it completely. That's hypothetical, yeah? Don't quote me. Okay, and yes, last question, yeah?
Why does it also increase uptake of pressure? Epinephrine is supposed to be more irritation.
So epinephrine will increase cardiac output and contractility. This is going to elevate slightly arterial pressure. However, in order for arterial pressure to be increased, then you need to close the blood vessels. And you do this only by norepinephrine, the constriction. It's a form of hemodynamics, if you know what I mean. So it's like when you're holding the hose, the watering hose, and when you close it, you restrict the pressure, right? When you just bend it a little bit, you increase the pressure. It's the same thing that happens with the heart. You increase the pressure by just closing the output.
And when you close it, all this sort of the nerve, right?
Yes, exactly. Let's take attendance.